Hello everyone. Today we will be discussing about proprioceptive neuromuscular facilitation, that is also known as PNF. Proprioceptive neuromuscular facilitation. Proprioceptive neuromuscular facilitation (PNF) is an approach to the patient care which has originated in the 1940s by Herman Cabot, MD. Maggie Nord joined himself in his effort to discover and refine the approach in the late 1940s. They soon began to teach the PNF to graduate physical therapists from all over the world. Dorothy was one of the first students in this program, and upon completion of the program, she joined Maggie's staff, and together they wrote the first edition of the PNF book. The basic principles to the PNF. Proprioceptive neuromuscular facilitation is an integrated approach. Each treatment is directed at a total human being, not just a specific problem or body set, based on the untapped existing potential of all the patients. The therapist will always focus on mobilizing the patient's reserves. The treatment approach is always positive, reinforcing and using that, which the patient can do. On a physical and psychological level, the primary goal of all treatment is to help the patient achieve their highest level of function. To reach this highest level of function, the therapist integrates principles of motor control and motor learning. This includes treatment on the level of body structures, on the activity level, as well as on the participation level. International Classification of Functioning by WHO. Definition and PNF philosophy. Proprioceptive means having to do with any of the sensory receptor that give information concerning movement and position of the body. Neuromuscular is involving the nerves and the muscles. Facilitation is making the things easier. Together, proprioceptive neuromuscular facilitation is a concept of treatment. Its underlying philosophy is that all human beings, including those with disabilities, have untapped existing potential. PNF philosophy. First point, positive approach, no pain, achievable task, set up for success, direct and indirect treatment, strong start. Second, highest functional level, functional approach, ICF, include treatment at the body structure level and activity level. Third, mobilize potential by intensive training, active participation, motor learning, self-training. Fourth, consider the total human being, whole person with his, her environmental, personal, physical, and emotional factors. Fifth, use of motor control and motor learning principles. Repetition in a different context respects stage of motor control variability of practice. The basic neurophysiological principles. The work of Sir Charles Sherrington was important in the development of the procedure and techniques of PNF. The following useful definitions were abstracted from his work. After discharge, the effect of stimulus continues after the stimulus stops. If the strength and duration of the stimulus increases, the after discharge increases also. The feeling of increased power that comes after maintained static contraction is a result of that discharge. Temporal summation. A succession of weak stimuli, subliminal, occurring within a certain short period of the time, combine, summate to cause excitation. The spatial summation, weak stimuli applied simultaneously to different areas of the body reinforce each other summate to cause excitation. Temporal and spatial summation can combine for the greater activities. The irradiation, this is spreading and increasing the strength of the response. It occurs when either the number of stimuli or the strength of the stimuli is increased. The response may be either excitation or inhibition. Successive induction and increased excitation of the agonist muscle Following stimulation, contraction of the antagonist, technique involving reversal of the antagonist make use of the property. Stimulation, increase excitability. Reciprocal innovation, reciprocal inhibition. The contraction of muscle is accompanied by simultaneous inhibition of the antagonist. Reciprocal innovation is a necessary part of coordinated motion. The relaxation techniques make use of this property. The nervous system is continuing throughout its extent. There are no isolated parts. The uses of PNF. The uses of proprioceptive neuromuscular facilitation is first, the proprioceptive neuromuscular facilitation treatment has been used in increase for strength, flexibility, coordination, and functional mobility. Second is to main goal of the treatment is to facilitate the patient in achieving a movement or a posture. Third is the stretches as well as the diagonal and rational exercise pattern are used to improve the activities in daily living to gain the functional mobility and athletic performance. Fourth, it is mainly used in the orthopedic rehabilitation for the musculoskeletal injuries and neurological rehab. PNF can be used for any condition, however, the patient condition level may require the modifications. Moving on to the basic neurophysiological principle of PNF, the diagonal of movement, innate path in which maximal response of the trunk and extremities can be facilitated. Its components associated with the antagonist motion are the flexion versus extension, abduction versus adduction in the extremities, and lateral movements of the trunk, internal versus external rotation. Moving on to the normal coordinated pattern of the motion are diagonal in direction with spiral components facilitates the strongest output. It reflects functional relationship of trunk and extremities. The diagonals may be used to identify the quality of contractions, range of motion, functional impairment, and the limitations. The motor development. Proprioceptive neuromuscular facilitation is based on 11 principles drawn from neurophysiology, motor learning, motor behavior. The examination and evaluation of the assessed areas are first to impaired range of motion muscle length, impaired muscle power, impaired muscle endurance, impaired balance, impaired posture, impaired motor control, and pain. Factors that included during the evaluation are the patient's short-term and long-term goals, patient receptive potential for the language, vision, manual context to promote cueing, patient strength, patient's weaknesses. The treatment implementation is by innovation may include modification of environment, education and compensation for the impairment, treatment directed at changing the patient's neuromuscular capabilities. The patterns of facilitation. Manually resistive exercise that create diagonals of movement by coupling pairs of antagonistic pattern, providing a path for reversing motion. And using the agonist antagonist relationship of the nervous system as techniques are applied. Its procedures are the body positioning and mechanics, manual contact, manual and maximal resistance, irradiation, verbal and visual cueing, traction and approximation, stretching, and time. The basic principle of PNF are resistance, irradiation and reinforcement, manual contact, stretch, verbal command, traction and approximation, timing, body positioning, and body mechanics. First up is the resistance. Opposing force to the patient's movement is called as resistance. The amount of resistance provided during an activity must be corrected for the patient condition. And the goal of the activity is called as optimal resistance. Resistance is used in treatment to first facilitate the ability of the muscle to contract, to increase motor control, to help the patient gain an awareness of the motion and its direction, and to increase the strength. Irradiation is the spread of the response to the stimulation. This response can be seen as increased facilitation or inhibition. In the synergistic muscle and pattern of the movement, this response increases as the stimuli increases. In intensity or duration, Sherrington and Cabot wrote that it is resistance to the motion that produces irradiation, and the spread of the muscular activity will occur in specific pattern. Reinforcement and reinforcement, as defined in Webster's Ninth New Collegiate Dictionary, is to strengthen by fresh addition and make stronger. The therapist directs the reinforcement of the weaker muscle by the amount of resistance given to the stronger muscle. Increasing the amount of resistance will increase the amount of extent of the muscular response. Manual contact effects stimulate the muscle, stimulates the synergistic muscle to reinforce the movement, promotes strong stabilization and indirectly helps the limb motion, and last, prevent the confusion. Moving on to the touch or manual contact, it contributes to facilitation by stimulating the exteroreceptors, and it should be purposeful, directionable, and comfortable. The stretch. The stretch stimulus occurs when the muscle is elongated. The lengthened position of the muscle is the starting position of each pattern, and the stretch is maintained throughout the movement. All the components of pattern must be stretched simultaneously. Hence, its effects are stimulates the activity of muscle spindle. Any contraction of muscle on stretch will result in the movement. And the brain knows not of the muscle but of movement. A quick stretch here, as you can see, alpha motor neuron taking it to the dorsal root ganglion to the muscle spindles. Traction. Traction is the elongation of the trunk or an extremity, not force, and the colleague theorized that the therapeutic effect of tractions are due to stimulation of receptors in the joint. Versatile traction also acts as stretch stimulus by elongating the muscles. Apply the traction force gradually until the desired result is achieved. The traction is maintained throughout the movement and combined with appropriate resistance. Traction is used to facilitate motion, especially pulling and anti-gravity motion, aid in elongation of muscle tissue when using the stretch reflex, resist some part of the motion. For example, use traction at the beginning of shoulder flexion to resist scapula elevation. Traction of the affected part is helpful when treating patients with the joint pain. Approximation. It is the compression of the trunk or an extremity. The muscle contraction following the approximation are thought to be due to the stimulation of the joint receptor. Another possible reason for the increased muscular response is to counteract the disturbance of the position of posture caused by the approximation, given gradually and gently. Approximation may aid in the treatment of the pain and unstable joints. Approximation is used to promote stabilization, facilitate weight bearing and the contraction of the anti-gravity muscles, facilitate upright reaction, resist some components of motion. For example, use approximation at the end of the shoulder flexion to resist scapular elevation. The verbal stimulation of the command. The volume with which the command is given affects the strength of the resulting muscle contraction. Louder the command when the strong muscle contraction is required. Softer and calmer the tone when the goal is relaxation and the relief of pain. The verbal stimulation, the command is divided into three parts: preparation, action, and correction. In preparation, we get ready for the patient for the action. Action tells the patient to start the action. Now pull your leg up or in. Correction tells the patient how to correct and modify the action. Keep pulling your toes up. The command used as hold, pull, push, relax. Timing is the sequence of motions. Normal timing of the most coordinated and efficient motion is from distal to proximal. Timing for emphasis involves changing the normal sequencing of motion to emphasize a particular muscle or desired activity. Body position and body mechanics. The therapist's body should be in a line of motion. Shoulder and pelvis face the direction of motion. The therapist stands in box standing position. The distance comes from the therapist's body, while the hand and arm stay comparatively relaxed. The body position and body mechanics give the therapist effective control of the patient motion, facilitate control of the direction of the more resistance. It enables the therapist to give resistance without fatigue. Johnson and Saliba first developed the material on the body position. Here are the techniques of PNF. The strengthening techniques are rhythmic initiation, repeated contraction, slow reversal hold, rhythmic stabilization. In stretching techniques, we have contract relax, pull relax. In rhythmic initiation, the progression from agonist pattern and passively it is active assisted or active. Used in limited ROM due to increased tone who are unable to initiate movement. The repeated contraction, patient move isotonically against maximal resistance repeatedly until fatigue is evident. When fatigue is evident, then a stretch at the point in range should facilitate the weaker muscles and results in the coordinated movement, which is used to develop strength and endurance. Slow reversal involves isotonic contraction of the agonist followed by immediately by an isotonic contraction of the antagonist. It is used for the development of active range of motion and the normal reciprocal timing between agonist and the antagonist. Next up, slow reversal hold involves isotonic contraction of the agonist followed by immediately by an isometric contraction with a hold command given at the end of each active moment. It used in developing strength at a specific point in the range of motion. Rhythmic stabilization uses an isometric contraction of the agonist followed by an isometric contraction of the antagonist. It is used to increase the strength and endurance. Stretching technique, PNF stretching, it is often a combination of passive stretching and isometric contraction. Encourage flexibility and coordination throughout the limb's entire range of motion. The PNF is used to supplement daily stretching and is employed to make quick gains in the range of motion to help athlete improves performance. The good range of motion makes better biomechanics. It reduces fatigue and helps prevent overuse injuries. Next up, we have the contract relax. It moves the body part passively into the agonist pattern. Patient is instructed to push by contracting the antagonist isotonically against the resistance. It's used in when the range of motion is limited by the muscle tightness. Hold relax. Begins with isometric contraction of the antagonist muscle resistance followed by concentric contraction of the agonist muscle. As you can see the PNF stretching position, the initial movement is in the direction of the stretch. Next, the athlete pushes in a direction against the stretch. The last movement is repeated of the initial. PNF patterns. Each pattern has three dimensions: flexion, extension, abduction, adduction, and rotation. Movement occur in a straight line in diagonal direction with a rotatory component. Here's an upper extremity, uh, as you can see, flexion, abduction, external rotation, flexion, adduction, external rotation. Down there we have extension, abduction, internal rotation. Here we have extension, adduction, and internal rotation. The patterns are of D1 flexion. Include shoulder flexion, adduction, external rotation, forearm supination, wrist radial flexion, fingers flexion. In D2 flexion, the shoulder flexes, abduction, external rotation. The forearm gets supinated, wrist radial flexion, in fingers in extension. The D2 extension is shoulder extension, adduction, internal rotation. The forearm pronation, wrist ulnar extension, fingers flexion. In D1 extension, shoulder extension, abduction, internal rotation, forearm pronation, wrist ulnar extension, fingers extension. Here as you can see the diagonal pattern of D1 and D2 flexion. As you can see here, the arm is going in flexion, adduction, and external rotation. Is the D1 extension, it's the D1 flexion. In lower extremity, it's same. In D1 flexion, we have flexion, abduction, internal rotation. Down we have external adduction, external rotation. Then again under D2 flexion, we have flexion, adduction, external rotation. In extension, we have extension, abduction, internal rotation. Here we can see in the lower limb. Here are some D1 lower extremity movement pattern moving into flexion and starting position. Now moving on to the lower trunk, the limb which is moving into flexion, the limb which is moving into extension. As you can see, the body part, the starting position is extension, terminal position flexion, and left hip it's going the same, extended, flexed. The starting position is flexed, the terminal position is extended. In ankle is the same, the plantar flex, the terminal position is dorsiflex. The hand position of athletic trainer, right hand on the dorsum of the feet, the left hand on the anterior lateral surface of the left knee. The vertebral command includes pull up and in. The moving into extension, right hand on the plantar surface of the foot, left hand on the posterior lateral surface of the foot. As you can see in the upper limb, it's the same. In right upper extremity, there's flexion, extension, Left upper extremity, flexion, extension. Trunk rotated and extended. Head, it is rotated and extended to the left. Moving on. Yeah, as you can see in the figures. PNF in sports. Here are some other general guidelines when completing the PNF stretching. Leave 48 hours between PNF stretching routines. Perform only one exercises per muscle group in a session. Third, for each muscle group, complete 2 to 5 sets of the chosen exercise. Fourth, each set should consist of the one stretch held for 30 seconds after the contracting phase. Fifth is PNF stretching is not recommended for anyone under the age of 18. If PNF stretching is to perform as a separate exercise session, as through warm up consisting of 5 to 10 minutes of light aerobic exercise and some dynamic stretch must proceed. The summary is PNF is a manual therapy approach that applies posture, movement pattern, contacts, cues, and goals. All equals to maximally facility. Treatment is based on improving function and using function that are possible to reach those are attainable goals. PNF lands itself to use an adjoint to other treatment approaches. As a journal of athletic training, PNF techniques are most frequently applied during rehabilitation of the knee, shoulder, and hip. Ankle rehabilitation has increased. The most frequently used techniques were contract relax and hold relax. The uses of PNF techniques in the muscles re-education is a phase of rehabilitation. As you can see, the PNF stretching to improve the range of motion uses the stretch reflex, muscle spindles, Golgi tendon organs by autogenic inhibition. Inhibition mediated by afferent fibers from a stretched muscle acting on the alpha motor neurons, causing the muscle to relax. It's the principle of muscle energy technique. The reciprocal inhibition again, the relationship on an agonist and antagonist muscle. Excitatory impulses are received by afferent nerves. Nerves that go into antagonist muscles are inhibited by the afferent impulses. The PNF stretching is the most effective proprioceptive neuromuscular facilitation technique combined concentric contraction of agonist and static contraction of the antagonist muscle. Recommendation and augmented range of motion 3-second contraction holds, 20% max, 30 to 60 second total duration with one repetition minimum, twice into a week. Note, these recommendations are based on research using healthy population. That's all it about the proprioceptive neuromuscular facilitation. Thank you.